In my previous lecture, we have learned about the management of acute gout. Today's session focuses on the management of chronic gout. Gout is a metabolic disorder that is characterized by sustained hyperuricemia. So hyperuricemia can be due to increased synthesis of uric acid, and it can also be due to decreased excretion of uric acid by the kidneys. In majority of the patients, hyperuricemia is due to decreased excretion through the kidneys, and in few patients, hyperuricemia is due to increased synthesis of uric acid. So elevated blood levels of uric acid can lead to acute attacks of gout. There is redness, swelling, tenderness, pain, and the common site that is affected is great toe. The management of acute gout includes non-steroidal anti-inflammatory drugs, corticosteroids, and colchicine. In between acute attacks of gout, there are periods of low-grade inflammation. This is known as chronic inflammation, and persistent hyperuricemia results in chronic gout. So what are the cardinal features of chronic gout? This is the figure which shows the cardinal features of chronic gout. It is characterized by persistent hyperuricemia, elevated blood uric acid levels, and this causes deposition of uric acid in the tissues, joints, synovial tissue, and there is formation of tophi. Now what is tophi? These are uric acid crystals that are surrounded by inflammatory cells and gives rise to inflammation. Also, the uric acid crystals can be deposited in the interstitial tissue of the kidney. There can be crystallization of uric acid in the urinary tract, leading to a decline in kidney function, fibrosis, inflammation, and urate nephropathy. So, kidney can be affected in chronic gout. So, the cardinal features of chronic gout are hyperuricemia, tophi formation, and urate nephropathy. The therapeutic goal in the management of chronic gout is treatment of hyperuricemia. So hyperuricemia can be reduced, can be controlled by using drugs that decrease the uric acid synthesis or uric acid synthesis inhibitors. Hyperuricemia can also be controlled by increasing the excretion of uric acid in urine by the kidneys. So there are uricosuric drugs. And also there is a third class of drug known as recombinant uric acids that oxidizes uric acid. So we will be dealing with each of these classes in details. So let's see what is the management of chronic gout. We have the uric acid synthesis inhibitors, that is allopurinol and febuxostat. So allopurinol and febuxostat are classified under uric acid synthesis inhibitors. They decrease the uric acid synthesis. Amongst the uricosuric drugs which increase the excretion of uric acid by the kidneys, the drugs are probenecid, sulfenpyrazone, and benzbromaron. So probenecid, sulfenpyrazone, and benzbromaron. So these are the three drugs that increase the excretion of uric acid by the kidneys. Then we have recombinant uric acids. Now what are uric acids? They oxidize uric acid. These are recombinant uric acids, and the drugs are pegloticase and rasburicase. So pegloticase and rasburicase are recombinant uric acids that can be used in the management of chronic gout. Now let's discuss the drugs that are used in the management of chronic gout. So drugs that decrease the synthesis of uric acid or uric acid synthesis inhibitor, and the drugs are allopurinol and febuxostat. So how does allopurinol act in the management of chronic gout? As you can see in this figure, purines such as hypoxanthine and xanthine are converted into uric acid in presence of an enzyme known as xanthine oxidase. So xanthine oxidase is a key enzyme that catalyzes the conversion of hypoxanthine and xanthine to uric acid. Now allopurinol acts by inhibiting xanthine oxidase enzyme, thereby decreasing the uric acid synthesis. Also to be noted that allopurinol is a short-acting drug. It is a short-acting competitive inhibitor. It gets converted into a metabolite which is known as alloxanthine. Now alloxanthine is a non-competitive inhibitor of xanthine oxidase, and it is long acting. It has a T-half of 24 hours. So alloxanthine, a metabolite of allopurinol, is primarily responsible for inhibiting the xanthine oxidase enzyme, thereby decreasing the uric acid and controlling the uric acid levels. Also to be noted that by decreasing the uric acid synthesis, the levels or the concentrations of hypoxanthine increases. And because the concentration of purines increases, there is some amount of feedback inhibition that decreases the release of purines from the nucleic acids into the circulation. So because of feedback inhibition also, there is decreased release of purines, decreased synthesis of uric acid, and together it helps in controlling the uric acid level, and this helps in the management of chronic gout. The treatment with allopurinol decreases the uric acid levels, thereby decreasing the plasma urate levels, decreasing the urate deposition in the tissues, decreases tophi formation, decreases deposition of urate crystals in the tissues, and crystallization of uric acid in the urinary tract is decreased. There is decreased formation of kidney stones. Now let's see what are the indications of allopurinol. Allopurinol is the first line drug for the management of chronic gout. Now when the body urate load is large, allopurinol can be combined with probenecid. Probenecid is a uricosuric agent, and combination of allopurinol with probenecid helps to control hyperuricemia and is used in the management of severe gout. So allopurinol, by decreasing the synthesis of uric acids, inhibits the formation of renal stones. So renal stone formation is inhibited with the help of allopurinol. Allopurinol can be used in secondary hyperuricemia. So there are certain conditions of secondary hyperuricemia such as cancer chemotherapy, radiotherapy, or treatment of myeloproliferative disorders or blood dyscrasias, where because of the treatment there is excessive cell destruction, releasing large quantities of purines into the blood, and this leads to the formation of uric acid. This raises the uric acid level, and these are conditions of hyperuricemia. Also there are certain drugs such as thiazide diuretics that raise the uric acid levels, and these are conditions of secondary hyperuricemia where allopurinol can be used as a treatment. So allopurinol in the treatment of secondary hyperuricemia. The next use of allopurinol is kala-azar. So allopurinol can be combined with sodium stipogluconate in the treatment of kala-azar. As we know that kala-azar is caused by Leishmania donovani, which is the causative organism, and allopurinol, by altering its purine metabolism, inhibits Leishmania donovani, the causative agent for kala-azar, and thus helps in the treatment of kala-azar. So allopurinol in the treatment of kala-azar. Now the next use is allopurinol can potentiate the actions of certain drugs such as 6-mercaptopurine, which is an anti-cancer drug, and azathioprine, which is an immunosuppressant drug. Now these drugs are metabolized by xanthine oxidase, which is the same enzyme that is inhibited by allopurinol. So allopurinol, by inhibiting xanthine oxidase, decreases the metabolism of mercaptopurine, thus enhancing the actions of 6-mercaptopurine and azathioprine. So in this way it helps to potentiate the actions of both these drugs. In terms of adverse effects, hypersensitivity reactions are frequent with allopurinol such as rash, fever, arthralgia, myalgia, lymphadenopathy, hepatitis. On stopping allopurinol, these signs and symptoms disappear, they resolve. However, allopurinol should not be restarted in these patients because serious reactions may follow. Other side effects such as nausea, headache, dizziness, dyspepsia can occur with allopurinol. Next we come to febuxostat. It is a non-purine xanthine oxidase inhibitor. It is non-purine, it lacks purine nucleus, and it is a xanthine oxidase inhibitor. Like allopurinol, it inhibits xanthine oxidase, thereby decreasing the synthesis of uric acid and acting as a uric acid synthesis inhibitor. It is equally or more effective in reducing the synthesis of uric acid. In terms of adverse effects, unlike allopurinol, which is known to cause hypersensitivity reactions, in case of febuxostat, hypersensitivity reactions are rare. The most important adverse effect is liver damage. So liver damage is the most important adverse effect. There can be elevation of liver enzymes, and therefore monitoring of liver enzymes is essential. Also, febuxostat is known to have caused cardiovascular events causing death in patients. So febuxostat is known to cause cardiovascular events. So liver damage, cardiovascular events are some of the important adverse effects related to febuxostat use. But do remember that febuxostat should not be combined with allopurinol. It is used as an alternative drug to allopurinol in case of allergy or the patient is unresponsive to allopurinol. So febuxostat can be used as an alternative to allopurinol treatment. Next we move on to uricosuric drugs, and the drug is probenecid. Probenecid acts by blocking the organic ion transporters that are expressed at various sites including the kidney. So it blocks the active transport of organic acids by the transporters expressed in the kidney. So urate transporter URAT1 transporter, which is a member of organic ion transporter protein, is expressed in the proximal tubule of the kidney. Now do note that this transporter is responsible for reabsorption of uric acid from the urine, from the tubular urine into the blood, raising the uric acid level. So probenecid, by competitively inhibiting the urate transporter, decreases the reabsorption of uric acid, thus enhancing the excretion of uric acid in urine. So probenecid, by blocking the urate transporter 1 organic ion transporter, decreases the uric acid reabsorption and increases the excretion of uric acid and is helpful in the management of gout. So probenecid is the second line drug for the management of chronic gout and can also be combined with allopurinol for the treatment of severe gout. Now there are other uses of probenecid. For example, penicillin is secreted into the tubules with the help of a transporter. So probenecid, by blocking the transporter, inhibits the excretion of penicillin, thus leading to prolongation of duration of action of penicillin. So probenecid is combined with penicillin to prolong the duration of action of penicillin by acting on the organic ion transporter by blocking the transporter. Also, probenecid can be used in combination with cidofovir, a drug used for the treatment of cytomegalovirus retinitis. Cidofovir is considered to be a nephrotoxic drug, and combination with probenecid enhances the renal clearance of cidofovir and thus prevents nephrotoxicity, reduces nephrotoxicity of cidofovir in the treatment of cytomegalovirus retinitis. So probenecid, by blocking the organic anion transporters, is helpful in the management of gout. It is helpful in prolonging the duration of action of penicillin. It is also helpful in preventing nephrotoxicity that is caused by cidofovir in the treatment of cytomegalovirus retinitis. Now talking about the adverse effects of probenecid, the most common adverse effect is dyspepsia. Allergic dermatitis may also occur with probenecid. Caution is necessary in renal insufficiency. Most uricosuric drugs are avoided in renal insufficiency because they are dependent on the kidney function for their action. So probenecid is contraindicated in renal insufficiency. Also, probenecid is inappropriate for the treatment of renal stones. Adequate fluid intake is advised and use of a urinary alkalinizer is advised to reduce the acidity of urine, decreasing the formation of renal stones in urine. Now speaking about the other uricosuric drugs such as sulfenpyrazone and benzbromaron. Now sulfenpyrazone, the actions, the side effects are similar to that of probenecid. Some of the unique features of benzbromaron is that they are used in patients who are allergic to or refractory to probenecid or sulfenpyrazone. Secondly, they can be used in renal insufficiency, Unlike probenecid and sulfenpyrazone, so benzbromadone can be used in renal insufficiency, unlike probenecid and sulfenpyrazone that are contraindicated or avoided in renal insufficiency. Lastly, we move on to a new class of drugs known as recombinant uric acids that oxidize uric acid and decrease the uric acid levels. This includes pegloticase and rasburicase. So pegloticase and rasburicase are included, they are grouped under recombinant uric acids. These drugs are administered by IV infusion. They are immunogenic, they increase the formation of antibodies. They can increase the risk of infusion reactions and increases the risk of anaphylaxis. Therefore, these drugs are to be administered by professionals in a healthcare setting where facilities to manage anaphylaxis are available because they increase the risk for anaphylaxis and this has to be managed. These drugs are used in refractory gout when the patient is unresponsive to other treatment, so they can be used in the management of refractory gout.